Welcome to Module 2, Opioid Antagonists. My name is Elizabeth Skoy. I'm a professor at North Dakota State University, and I will be your speaker for this module. We have two learning objectives for this brief module. 1, recognize and respond to an opioid overdose. 2, describe and differentiate between available opioid reversal agents. Before we get into an opioid overdose, it's also important to understand how the opioids work in our body. So this slide shows how opioids work in our body to relieve pain. The opioids bind to a receptor called the mu receptor, and this mu receptor is located in areas throughout our body which control pain. You can see all the little numbers and circles here that signify where the mu receptor works in our body, such as our central nervous system and our brain to regulate pain, which is great and why they're so effective. However, the mu receptor is also located in other areas of our body, and these areas do not control pain. And so, for instance, when the opioid binds to the mu receptor, which is located in these other areas, this is where side effects come in. And because of that, the opioid will bind to areas that control our natural ability to breathe, our digestive system, and even our ability to be awake. And so that's why we see side effects such as respiratory depression or decreased ability to breathe. We'll see constipation, nausea and vomiting, and sedation, all as side effects from opioids. And this is where an opioid overdose occurs. So thinking back to that previous slide, we mentioned the side effects of opioids, and this is how we can recognize an opioid overdose. So when somebody isn't responding, if their breathing is slow or shallow, or they're making choking and gargling noises, these are signs of a possible opioid overdose. In addition, individuals might have blue lips or nails, cold and clammy skin, and tiny pupils. Again, these are signs and symptoms of possible opioid overdose. The good news is that we have opioid overdose reversal agents available to us. This picture shows how naloxone works in the body, but another opioid overdose reversal agent called nalmefene works the same way. You'll see these green columns, those are the receptors, and these are the receptors that are located in areas that control our ability to breathe, constipation, pain. That signifies the mu receptor. And those pink balls signify the opioid. So when the opioid binds the receptor, you get the effects that we previously talked about. However, when naloxone comes in, naloxone actually has a greater affinity for the mu receptor than the opioid. And so naloxone will kick the opioid off of that receptor, as seen here in this picture, and then bind to the mu receptor instead, thus reversing the effects that the opioid is having in the body. Now we'll go through the different naloxone dosage forms. The ones that you see here were some of the first naloxone dosage forms that were available and not used quite as much. The top is your classic vial of naloxone, which can be used as an injection and delivered intramuscularly. And then you also have intranasal naloxone. This is the generic intranasal naloxone, which actually utilizes an atomizer device, which attaches to a pre-filled glass syringe of naloxone in order to convert the syringe of naloxone into a nasal dosage form. If you were to use this, you would spray half of the syringe in one nostril and then half of the syringe in the other nostril. But again, since we now have newer dosage forms for opioid reversal agents available, these are not quite as frequently used any longer. Here we have another naloxone dosage form, and this is also an injectable, and it's called Zimhigh, and this is branded. It's 5 milligrams per 0.5 mils, and it's approved for individuals 12 years and older that are experiencing an opioid overdose. You can administer Zimhigh either subcutaneous or intramuscularly, and this is where the naloxone actually comes in the Zimhigh device, which kind of has some numbers and guides, and that kind of these guides talk you through, or at least walk you through, how to administer this injectable naloxone dosage form. Naloxone is also available over the counter in two different doses. It's approved for Narcan, which is in a 4 milligram per 0.1 milliliter dose, and that's intranasal administration. And also there's Revive, which is also approved for over-the-counter use, and it's 3 milligram per 0.1 milliliter. Both of these use the same dose device. It's approved for layperson, so really easy to administer. It has a device where you just place the device in the nostril, you push up, and the naloxone is delivered. But again, these two that are listed on this slide are available for over-the-counter use. We also have two other branded still. That means they're not available over the counter naloxone dosage forms for intranasal use. There's a Narcan dose of 2 milligram per 0.1 mil. And then also there's another device called Cloxato, which is an 8 milligram. So it's double the dose of naloxone per device than the over-the-counter naloxone, and that's 8 milligrams per 0.1 milliliters, and that's sprayed one device into the nostril. So some of the ideas behind these higher doses of naloxone that you're going to be seeing, like for instance this 8 milligram, is that the idea behind them is that they might be more effective against an overdose that's related to fentanyl. However, we're going to get to that in just here in a moment and discuss if that really is the case and if the higher dose is preferred. All right, and we also have another opioid antagonist that we're hearing about more recently, but it actually has been around for a really long time. It was pulled off the market and then brought onto the market more recently, and this is nalmefene. And nalmefene is available as an injectable and subcutaneous or intramuscular or IV. And the injectable nalmefene is actually more used in like an emergency or maybe a hospital setting, and it's not quite used that often in kind of out and about in the community in public. And then we also have an intranasal nalmefene, which is 2.7 milligram per 0.1 milliliter, and that's the same device as you'll see in the other intranasal naloxone devices. So something just to know about nalmefene and the difference between nalmefene and naloxone is that nalmefene actually has a higher binding for that opioid receptor. It's actually a 4 times greater higher binding, and it actually stays in the body a little bit longer. So we might look at that and think, well, that's good, and there are some benefits to that. However, with that, nalmefene typically has a little slower onset to action, and then it also has been shown to have a higher likelihood of withdrawal. And so just because you're providing, for instance, an IV nalmefene or even naloxone in an emergency setting like an IV or an emergency department doesn't mean that you no longer have to monitor those patients. And so for some of these, for nalmefene that stays in the body a little bit longer, it may require longer monitoring in emergency department because it just stays in the body longer than the regular naloxone. And so you might have to adjust that dose. The reason this is something to consider is that the opioid will typically stay in the body and circulate longer than like a nalmefene or a naloxone. And so what happens is once the nalmefene or the naloxone in the body wears off, that opioid might go back and bind to that opioid receptor and put that person back into an overdose situation. So there again, it's always really important to monitor patients, call 911 after someone has responded to an overdose situation to make sure that they're getting the proper medical attention and they don't go back into overdose. Here's just a quick picture on how to administer that intranasal nasal spray. And again, this is for pretty much all of the intranasal opioid reversal agents that we have out there. You have the nozzle and you have the plunger, and all you do is just press up on the plunger and then the spray goes through the nozzle to deliver the dose in the nostril. So now we're going to look at the effectiveness of the two different opioid antagonists that we have available, naloxone versus nalmefene. So like I said, in theory, since the nalmefene has a higher affinity for the opioid receptor and it stays in the body longer, we might think that it is better for reversing those synthetic opioids such as fentanyl. However, this really hasn't been shown to be the case. And so there really isn't any evidence of superiority of one over the other, of naloxone versus nalmefene. And there have been some statements, for instance, from the American College of Medical Toxicology that states that naloxone is still the preferred opioid overdose reversal agent. And the reason of that, again, is the potential higher side effects of the nalmefene versus naloxone, or even higher side effects of the higher doses of naloxone, particularly that withdrawal. And there's been studies that have shown that in communities where someone has seen an individual go through opioid reversal and save their life, but they also see them have those withdrawal symptoms, that when someone sees someone go through withdrawal, they may be more unlikely to respond to an opioid overdose, because those withdrawal symptoms are very real, and they're very intense. And so just something to consider. We want to make sure that we're having that life-saving agent, but we also want to balance that with not putting them through too many side effects with that withdrawal. And statistically, greater side effects do tend to happen with the higher doses of nalmefene, or with higher doses of naloxone and with nalmefene. Also, just to mention that neither of these opioid reversal agents, such as nalmefene or naloxone, do work against xylazine. Xylazine is a sedative or a tranquilizer, and it's a non-opioid, and so these medications won't work for them, against them. However, it is important to note that, and we've seen xylazine placed in some of the more illicit opioids that are out there and being distributed. However, one thing is to note that if you were to respond to a rescue where somebody has ingested an opioid combination with xylazine, that individual would probably restore their ability to breathe. So the opioid will work in that life-saving factor, but they may not wake up because the sedative and the xylazine is still there. So just to be aware of that naloxone won't, or nalmefene won't work on xylazine component, but xylazine is most commonly in combinations with opioids, so it will work against the opioid component and still be life-saving. And then again, there's been some studies that have looked at the injectable version of naloxone versus the nasal. There hasn't been any differences shown for pre-hospital management. Again, once you're in the hospital or you're in the emergency department, it's better to have an IV, an injectable administration, because you're able to titrate that dose and respond accordingly to what the patient needs. And there again, though, one thing to make note is that the intranasal onset of action is slightly longer than the injectable. So now that we've talked about the opioid antagonists themselves, let's just talk quickly about education and what we need to know when we're providing these life-saving medications to patients. So first, always letting them know that even though you administer the naloxone, they do need to call 911. And you can provide that education as to how I mentioned that the opioid may stay in the body longer than the opioid reversal agent, and we don't want them to go back into an overdose situation. If you do have a demonstration device for the intranasal opioid antagonist available, that would be ideal, and you can show the individuals how to use that. And then whatever dosage form that you do use for the opioid antagonist is to, if you have a patient handout for them, also that would be beneficial. When we're educating, also pointing out that there are 2 devices of naloxone in every, or opioid antagonist in every box that we provide. And that reason is because if there is no symptom improvement within that 2 to 3 minutes, we should provide that second dose of the opioid antagonist. There really isn't any adverse effects of the medication besides how they're working in the body. And so again, those withdrawal symptoms are going to be the adverse effects. So that flushing, the weakness, we've heard that it's like the worst flu that you've ever had, but also know that if somebody is taking an opioid due to alleviate pain, that when they wake up, that pain relief is going to be gone. And so they will wake up in a significant amount of pain. So also being aware of that. Storage conditions for the most part is room temperature, but a lot of the newer devices now do allow for short-term excursions of extreme heat or extreme cold, particularly if we think of a lot of emergency responders that might be out and about and maybe patrolling or something like that. If they have that with them, those short-term storage conditions are okay. Shelf life, always make sure to, if you have an naloxone or nalmefene on hand, to be looking at the expiration date and that shelf life of it, and making sure that we always have an in-date device if possible. And then also just educating patients on safety. There is no effect of these opioid reversal agents on somebody if they have not consumed an opioid. So if you were to come across somebody and they are laying on the floor and you check for them and they have maybe those signs and symptoms that would maybe align with an opioid overdose, but they're not an opioid overdose, but you give an opioid antagonist anyway, that patient will not have, or that person will not have any adverse effects of it. So if I took nalmefene or naloxone sprayed in my nose right now, I wouldn't have any effect besides maybe a tickle in my nose from the spray. And also, these medications do not produce tolerance, and so you can provide them over and over again, and they'll still get that same effect. When we're recommending naloxone, there's some evidence-based language that is more appealing to patients when they're accepting naloxone or nalmefene. And so when you're recommending it, telling them specifically for their particular need why you are recommending it. So an example is based on the fact that you are taking naloxone, or you're taking an opioid and you're also on a medication to treat anxiety, there is an interaction which could lead you more likely to experience an overdose. Because of that, we would say that you're a candidate for naloxone, for instance. So using that language, telling them specifically why it is that you're recommending it for them. Also letting them know that you're not targeting them and assuming that they're going to be in an overdose situation. Explaining that really all individuals that are prescribed opioids have some risk of overdose, and just normalizing it and letting them know that you really want that to be on hand as a safety precaution. So some of the other examples of that safety precaution is using an analogy, like naloxone and nalmefene is like a seatbelt, right? So you want it on hand, but you hope you never have to use it, like a fire extinguisher. Or every day I drive in the car, I put my seatbelt on because I'm hoping that I don't get in an accident, but if I were to get in a car accident, that seatbelt would save my life. That's the same reason why we want you to have this opioid antagonist on hand, is that we expect that you and hope that you won't have an overdose situation, but if you were to have one, this will save your life. So again, using those analogies for safety. And then finally, just answering some questions for patients, or being aware of the Good Samaritan laws in your own community, and letting them know that most all states now have some sort of Good Samaritan law, and so letting those individuals know that if they were to respond to an overdose situation, they typically are excluded from prosecution if they usually will stay with the person and cooperate with law enforcement and get them the help that they need for emergency response. So that concludes our module, and hopefully you learned some new information or reinforced information you already knew about opioid antagonists.